Welcome to Autopsy Pathology, the External Examination Lecture. Today we'll go over the basics of an external examination. We will also take the time to look at postmortem changes and how they can be used to calculate time of death, as well as the stages of decomposition. You have 4 cognitive learning objectives for this lecture. The first is to identify medical device types that cannot be removed during the external exam. Second is to calculate the time of death based off the external exam. Third is to discuss how extreme increase in physical activity prior to death can have significant impact on rigor mortis. And 4, describe the stages of decomposition. There are 2 effective learning objectives for this lecture. The first is to recognize the importance of the external exam in the PAD, and the second is to recognize the importance of maintaining anatomic location of specific medical devices. Before starting an autopsy, there's some prep work you need to do to make sure that the autopsy experience is successful, safe, and fun for you. The most important thing to look for at the time of the autopsy is the consent form. Every patient that comes into the morgue must have a consent form filled out by the appropriate next of kin. It's up to you to verify the presence of the form and that it's properly filled out. Additionally, the consent form will verify any restrictions that the family has placed on performing the autopsy. Also, take the time to gather and review as much clinical history as possible. This will differ depending on whether this is a hospital case or a forensics case, but some important things to consider are infectious organisms for possible safety concerns and medical devices to look out for during the autopsy. Additionally, if this is a hospital case, see if there's any indication that this could be a medical legal issue. When working on a hospital case, you will have a chance to contact the patient's clinical team. This is a great opportunity to gain additional information that may not be in the medical record. Also, the physician can provide insightful information into the suspected cause of death and help you focus your autopsy goals. For unusual cases or potential hazards, you may want to seek additional assistance in the way of residents, another PA, or even the PA student. As an autopsy is not an immediate medical emergency, you'll be able to plan a start time that is convenient for you and the lab. But be sure to notify Descendant Affairs when you expect to start so that they can make sure that everything is ready to go when you get there. Up to this point, everything was mostly administrative, so by now you may be standing in the morgue ready to go. But not so fast, there are still a few more steps to consider. First, make sure that the body you're looking at matches both the consent form and the medical history you reviewed. The patient should have some type of identification on them, such as a classic toe tag or medical bracelet, or in forensic cases some type of ID card that was found at the scene. This is a good time to do a callback with somebody. One of you reads the names off the paperwork and the other off for the patient. Make sure that there are no accidental oversights. Second, you can also take some time to lay out the necessary tools you plan to use for the autopsy on a separate table. Ideally, you want to set these up nearby for quick access, but not so close that you'll risk knocking them over during the process. Once cuts are made, things start to get a little messy, so it's a good idea to pre-blade multiple scalpels for easy swapping should one get dull. There are a wide range of tools that you'll likely use for an autopsy. These can include scalpels and knives for cutting organs, bone cutters and striker saws for getting through bone, forceps, balance, measuring tape and ruler, a needle and thread for closing the body afterwards, formalin and containers to store tissue, sterile containers if you suspect microbiology, a ladle for any fluids, and don't forget your blocks for processing the tissue. Now's a good time to take photographs. Most places will at least take an overview photo to conclude the case identifier, but don't forget to photograph pertinent findings from the external exam, such as distinguishing marks or signs of trauma. As you get ready to start, pre-label all your paperwork, cassettes, and containers to avoid possible mix-ups during the autopsy. And at last, you're ready to gown up. Everyone involved in the autopsy process should have some type of PPE, even if they're just taking notes. For those of you that are doing the cutting, be sure to wear a full gown with mask, face shield or goggles, hairnet, and shoe covers. It is recommended to wear cut-resistant gloves and double glove over them. It's likely that the first tissue you'll obtain for autopsies will be for ancillary studies. Nearly every autopsy will take blood samples regardless of whether any toxicology testing is done or not. The most common site for obtaining blood is peripherally at the femoral vein, but on occasion, central blood can be sampled from the heart or aorta. Vitreous fluid and urine are also often collected at the start of the autopsy as well. If microorganisms are suspected, tissue cultures can be obtained once the chest cavity is exposed. It's important to maintain as much sterility as possible when doing so, and oftentimes you'll scorch the tissue site prior to extracting tissue. Additionally, toxicology studies may be performed on kidney, muscle, liver, or bile samples, as these sites often contain the highest concentration of metabolites. With all that prep work out of the way, you're now ready to start examining the body and documenting your findings. So let's get right into it. One of the first things you'll do for the external examination is to take basic measurements. The most common measurements are the height, which is taken from the crown of the head to the heel, the chest circumference, and the abdominal circumference. Although most of what we do as pathologists is done in the metric system, it's a common practice to see external exam measurements done in inches and even feet. The reason for this is that often these measurements are presented in a courtroom setting, particularly in forensic cases, and most Americans are just not comfortable with non-metric units, unfortunately. You'll also need to include the weight of the patient, which is oftentimes taken prior to the body being brought to the autopsy suite. Once the patient has been weighed and measured, you can continue on with the rest of the exam. As you examine the body, you want to be as thorough as possible and document any unusual or interesting findings. These can be recorded on a sheet much like the one presented here. Note how the arrows and circles indicate the findings, and there's a description and measurements correlating to that specific site. It's also important to note that you want to be thorough, but not too thorough. Not every small nevi scar has to be documented, nor is it pertinent to the autopsy. Use your best clinical judgment when determining whether something should be documented or not. If this is a forensic case, be sure to identify, measure, and draw on the sheet any evidence of traumatic injury. With bullet wounds, you can attempt to trace entrance and exit points, but this will be correlated once you open the body. If this is a hospital case, it's not uncommon for medical devices to be present. Document the location of each of these devices. Describe them as best as you can. Generally, you'll want to leave these in place until you can verify their location internally, and we'll talk about this more later. Once you've established that the devices have been properly placed, though, they can be removed and disposed of. As you examine the body, I find it's best to look at the body as a whole before starting a systemic examination. This will help guide you on what to expect and clue you into possible findings. You can document the general state of the body, for example, if it's overweight or underweight, muscular or cachetic, and this can give you insight into the possible findings once you open up the patient. As you begin the systemic examination, the most common place to start is the head and work your way down. Note the presence of fluid from any orifices. This is not an uncommon finding, but it's worth mentioning the color and texture and the presence of any blood. Examine the scalp for possible fractures. Examine the hair, noting the unusual presence or absence of hair. Absence of hair on the scalp could be a clue to some type of treatment effect. Additionally, any females with facial hair would be a possible sign of an ovarian mass. Document the eye color as well as the color of the sclera. Also note the presence of any cloudiness, which is a classic indication of glaucoma. Finally, you'll want to examine the oral cavity. Depending on the degree of rigor mortis, the jaw may present some difficulty with opening, so be careful that you don't cut yourself on some teeth. You want to document the quality of the teeth, whether or not they're natural, and any potential findings that you may have learned in your fantastic clinical head and neck lecture. After the head, work your way to the chest. Palpate the ribs to detect the presence of any fractures. This may be a common occurrence in a hospital setting, as the patient could have undergone some type of resuscitation attempt. When working on a female, examine both breasts for signs of potential malignancy. This can be detected by a palpable mass or clinical signs such as peau d'orange, which presents as lymphedema of the overlying skin. Look at the symmetry of the chest and the axilla. Patients with COPD, for example, will present with an increased anterior-posterior diameter, and patients who might have metastatic disease could see enlarged lymph nodes in one or both of the axilla. After the chest, you can make your way to the abdomen. Check for any noticeable distension, which could be accounted for in the abdominal circumference you took earlier. Palpate for possible organomegaly, particularly with the spleen on the left side and liver on the right, to indicate any possible diseases. Hernias can also be detected in the lower abdomen and should be documented accordingly. After finishing the abdominal exam, it's a good time to roll the patient over and examine the entire backside. You want to document any wounds, scars, or unusual findings here too. Additionally, you can examine the rectum. The rectum is a great place to take the patient's internal temperature, as it's the most accurate reading for internal temperature. Now you can make your way to examination of the genitalia. Both male and female genitalia will often present with some type of edema referred to as anasarca. You can also look for penile or vulvar carcinoma and sexually transmitted diseases. In males, a common finding could be cryptorchidism. By palpating the scrotum, you can see whether or not the testes have descended. In females, you can look for prolapsed uteruses extending from the vulva, as well as any signs of sexual trauma or abuse, in which case this could present as a medical legal case. Finally, it's time to examine the extremities. Be sure to look at both sides of the hands and feet, as well as the nails, as nails are a good indication of the health of the patient. Also note any asymmetries. Polydactylism is a common occurrence in the fingers and toes, and you don't want to miss it. Also, make sure you document any sort of amputations or possible defects. You have now completed the external examination. Congratulations! Now let's take a look at medical devices and why it's important for you to be aware of their location. Using the external examination sheet we looked at earlier, you'll want to go ahead and document and record the location of every medical device and give a brief description of what that device is. There are some devices that we can easily remove without concern. These include bandages or any sort of superficial venous catheters. However, there are certain devices that we want to leave intact. These include central lines, endotracheal tubes, feeding tubes, and urinary bladder catheters. Now, the primary reason for this is that we want to verify their location, because misplaced medical devices such as these could have long-lasting complications on the patient and potentially lead to death. Central lines are also referred to as central venous catheters, or CVCs. The device is placed into a large vein such as the subclavian and allows the administration of medicine or fluids that cannot be taken orally, or if there would be an issue with giving them intravenously through smaller veins. It also allows continuous monitoring of central venous pressure and allows for easy removal of blood for blood testing. During autopsy, you'll want to make sure that the device is properly placed in the subclavian vein and that it was not inadvertently placed in an artery or in no vein at all. An endotracheal tube is tubing that is placed through the mouth or the nose and followed through the larynx into the trachea. The tubing opens the airway for administering oxygen, medicine, or anesthesia. It can be used to support breathing for respiratory illnesses or help remove blockages. It can also be used for visualization of the airway. Endotracheal tubes can also be used to protect the airway passages from aspiration in individuals who are unable to do so, such as those suffering a stroke, overdosing, or seizure. At the time of the autopsy, you want to verify that the endotracheal tube was indeed placed in the airway and not accidentally in the esophagus, as this would defeat the purpose of the endotracheal tubes. Pictured above is a gastrostomy, or a gastric feeding tube. These are typically made of polyurethane or silicone, and the tube is inserted directly into the stomach through a small incision in the abdomen and is used for long-term nutrition. These are typically used when swallowing is difficult because of neurological or anatomical disorders, such as strokes, esophageal atresia, tracheoesophageal fistulas, or radiotherapy for head and neck cancers. Additional types of feeding tubes may be placed through the nostrils, down the esophagus and into the stomach, and in some cases past the stomach all the way into the jejunum. At the time of autopsy, it's important to note proper placement of feeding tubes. For gastric feeding tubes, you want to make sure that they are securely attached to the stomach through the abdomen and do not by chance get dislodged and located into the abdominal cavity. For the nostril feeding tubes, you want to make sure that they followed all the way down into the esophagus, into the stomach, and did not by chance get into the trachea. Urinary catheters are latex, polyurethane, or silicone tubes placed into the patient's bladder via the urethra. This allows patients to drain urine freely and may also be used to inject treatment liquids. There are three main types of urinary catheters that you should be aware of. A Foley catheter has a balloon at the tip that is inflated with sterile water to keep the unit in place. A Robinson catheter, or intermittent catheter, has no balloon and so does not stay in place unaided, but it can be more flexible. And a Code catheter has a curved tip for easy application through the prosthetic urethras. During the autopsy, you'll want to make sure that the catheter was placed completely into the bladder. It's also worth noting that catheters tend to cause bladder wall trauma. It's not uncommon to open up the bladder and see hemorrhagic mucosa. This can be correlated if you know that the patient did have a catheter in place. The last type of devices we'll look at today are electronic medical devices. There are three ones we'll mainly concern ourselves with, and those are deep brain stimulation, or DBS, implantable cardioverter defibrillators, or ICDs, and pacemakers. Deep brain stimulation devices are implanted electrodes in the brain that are used to treat movement in neuropsychiatric disorders. For non-Parkinson's conditions, electrodes are placed in the thalamus, but for Parkinson's you'll see them placed in the globus pallidus. The battery is typically located at the clavicle area on one side of the body. It's important to note that this might need to be deactivated prior to the autopsy beginning. ICD devices are implanted devices capable of correcting most life-threatening cardiac arrhythmias. They are used for patients that are at increased risk for sudden cardiac death. Modern versions tend to also function as a pacemaker. A pacemaker alone will only be used to maintain a regular heart rate. You'll see these electrodes placed into the AV node. At the time of autopsy, you'll see the battery placed in the chest, and this will often have to be deactivated safely prior to continuing. When you dissect the heart, you can also ensure that the electrodes are properly placed in the AV node. Before we get into postmortem changes, I'd like you to take a few moments to contemplate what it really means to be dead. We have a couple of definitions for death. There's brain death, when your brain ceases to have any sort of function. Circulatory death, when your body ceases to pump blood throughout the rest of your body, resulting in organ failure. And then finally, cell death. Brain death and circulatory death are gross manifestations of death, and the easiest for us to understand, with circulatory death being by far the more common presentation. These are sometimes referred to as clinical death. With circulatory death, the lack of flowing blood eventually leads to the death of the rest of the organs, including the brain. However, brain death presents an interesting philosophical discussion, as the circulatory system is often still functioning, as are the rest of the organ systems. Some cultures maintain that even when the brain ceases to function, the body is very much alive, and so too is that individual. Either way, both of these represent a gross presentation of being dead, and are something that we can easily use as markers for death. Cell death, on the other hand, occurs on the microscopic level after we determine a person to be dead, and is a time when all the cells in the body have necrosed. This is the beginning of decomposition, and can take hours, days, or even weeks for all the cells of the body to truly die. The period between the macroscopic death and microscopic death gives us an interesting period known as the supravital period. During this time, some of the reflexes and vital functions of the body may still present, even though the patient is clinically deceased. One of the more interesting supravital signs is known as Zarco's phenomenon. This can be seen in patients that died as recent as 2 to 3 hours, or in surgical specimens such as amputations. Mechanical stimuli of large muscle groups such as biceps or quadriceps results in entire contractions of the muscle group. It's quite startling to see, and it looks like the muscle is actually alive. After the 3-hour window, but before full rigor mortis sets in at 12 hours, you can also experience Zarco's reflex. This is a very similar process, except instead of the whole muscle contraction, you get just a bulge at the site of stimuli. Stimulus can be something as simple as using a scalpel blade to cut through the muscle. Go ahead and try it yourself on the next amputation specimen you get. For the remainder of this lecture, we're going to look at cadaveric changes that occur post-mortem. That includes livor mortis, rigor mortis, algar mortis, and stages of decomposition. The first 3 complete a cycle within 36 hours and are useful for determining time of death during that period. The first change we'll talk about is livor mortis, which literally means the bluish color of death. Livor mortis is the gravitational pooling of blood after circulatory death has occurred. Once the blood stops flowing, gravity will pull the blood down to the path of least resistance. Depending on how the body is found or lying at the time of death will dictate the pattern of livor mortis. And any sort of external pressure can actually blanch particular areas. As you'll see in the bottom picture, it looks like this person may have been holding a gun. In the top picture, we can surmise that maybe this person was laying over a chair or potentially had a seatbelt in place. A lividity pattern begins to appear about 30 minutes to 2 hours after circulatory death. The blood will continue to pool until it becomes fixed at about the 8 to 12 hour mark. Before that time, it is possible for the livor pattern to move and shift depending on external pressures applied to the body, including using a thumb or finger to apply pressure to an area of pooling, which would be met with displacement. What this means is that if you can displace the livor pattern in an area of the body, it is likely that the person has been dead for less than 8 hours. If the lividity is fixed and cannot be displaced, we can assume that death took place more than 12 hours ago. This can also be used to determine if a body has been moved depending on how the lividity pattern presents compared to the position of the body. If the person is on their back but we see a bluish color on the anterior aspect of the body, it's safe to assume that the body was likely moved after lividity fully set in. Now, there are a few things worth taking into account when observing lividity. First, the color of the lividity can be a clue to the cause of death. Normal lividity should appear bluish purple, but in individuals who are exposed to carbon monoxide, you'll see a cherry pink color. Note, however, that refrigerated bodies can produce a similar effect. Cyanide poisoning can result in a bright red color, and phosphorus poisoning is indicated by a dark brown lividity. Individuals who have lost a lot of blood or were anemic will show a pale pink color pattern, and sometimes livor can be barely seen in these cases. Second, drowning victims will exhibit a unique pattern to lividity. The pooling blood will tend to line up with the water level as the water provides a buffer to the gravitational pull. This means you'll likely see a horizontal line across the entire body, with the likely locations being the face, upper chest, hands, feet, and calves. Finally, most of the blood pooling in lividity remains in blood vessels. However, when the pressure in the vessels gets too great, the capillaries can rupture, creating petechial hemorrhaging referred to as Tardot spots. This can be seen in hangings, whether the entire person is hanging, where you would see it in the feet, or parts of the body overhanging ledges. Before moving on, we have one last fun fact about livor mortis that you can share with your friends or family on your next get-together, and this is demonstrated in the picture at the bottom right. When males hang themselves, the blood will pool towards the feet, legs, and pelvis. This means that there's going to be enough blood to fill the cavernosus arteries in the penis. This results in a very startling sight, known as a death erection, that you can see right here. Next up, we're going to talk about rigor mortis, which translates to stiffening of the dead. The image here is a good demonstration of just how stiff the dead can get, but I don't recommend trying this during your autopsy rotation. After the body dies, ATP, which is a necessary component for making your muscles go back to a relaxed state, is rapidly depleted. As a result, actin and myosin bind together, creating stiff muscles. Rigor mortis typically follows a streamlined process of starting off very lightly and gradually increasing until the whole body is rigid. The process also starts in small muscle groups like the fingers and toes before moving on to larger muscle groups such as those in the back and thigh. As rigor disappears, it does so in a similar pattern to the way it first appeared, starting in the small muscle groups before moving on to the larger. For those of you that want to go the extra nerdy mile, which I imagine is everyone, let's take a quick look at the science behind rigor mortis. As the muscles start to experience cell death, the once secure cell membranes can now be breached by calcium ions. These were typically pumped out and kept out by ATP. The calcium ions are just the thing needed to cause actin and myosin fibers to cross-bridge, and with the abundance of calcium ions, these muscle fibers keep ratcheting up and getting tighter, creating the characteristically rigid look to rigor mortis. Full rigidity is reached between 12 and 24 hours. After about a day of this, the cells start to break down completely. Lysosomal enzymes are released and begin breaking down the actin and myosin fibers, causing the rigidity to eventually disappear, as the muscle essentially returns to a relaxed, although decomposing, state. The rigor mortis timeline takes place over approximately a 36-hour time period in ideal conditions. It will first start to appear about 2 hours after death and will gradually spread and increase rigidity until reaching full rigor at about the 12-hour mark. This rigidity will hold for another 12-hour window in ideal conditions before the muscles start to break down at the 24-hour mark. The disappearance of rigor typically takes another 12 hours to complete, with the body becoming completely flaccid by the 36-hour mark in ideal conditions as the body continues to decompose. Just like in livor mortis, moving a body can disrupt the development of rigor mortis. Rigor can be broken while developing or when fully developed by moving a muscle group such as those found in the limbs. Once broken, rigor will not return to those muscle groups. So finding flaccid muscles in a body that is otherwise fully rigid can yield clues about the circumstances surrounding the body post-mortem, indicating that the body was likely moved somewhat. When using rigor mortis to estimate the time of death, it's important to consider any possible factors such as those listed here that can skew the timing. Anything that can accelerate muscle breakdown and ATP depletion, such as exercise, electrocution, and acidosis, will often mean that rigor mortis will become complete and disappear within a shorter window, sometimes as quickly as 12 hours for the entire process. There are occasions when rigor mortis can instantaneously develop at the time of death. This is referred to as a cadaveric spasm. Typically, this is seen in individuals who experience vigorous physical activities or struggles just before death, resulting in complete depletion of all ATP available. Cadaveric spasms are somewhat rare and are often associated with high body temperatures or violent exertion, such as people who struggle before drowning, leaving a tightly clenched fist full of grass and weeds. As rigor mortis sets in, you'll likely see some interesting effects on the body. The muscles of the heart will contract during this process, resulting in expulsion of blood from the heart chambers, which you might notice when dissecting the heart during an autopsy. On the scan, you may see goosebumps as the erector pili muscles contract throughout the entire body. And in males, the muscles surrounding the scrotum and prostate will result in emission of semen as rigor mortis sets in. The final mortis we'll talk about is algor mortis, which translates to the chill of death. Algor mortis is a common method used with the belief that the body cooling most accurately dictates the approximate time of death. This is based off a few assumptions, namely that we have a normalized body temperature at the time of death and that the body cools at a uniform rate. Unfortunately, both of these assumptions easily break down in the real world. The basis for algor mortis is that the body will hold its normal temperature for about 2 to 3 hours after death. After that time, the body will steadily cool about 1 degree Celsius per hour until the body reaches equilibrium with the environment. It's worth knowing that the typical body temperature is approximately 37 degrees Celsius, and ambient room temperature tends to fall within the 23 to 25 degrees Celsius range. When checking for algor mortis, it's best to obtain temperatures from the body either from the rectum or within the liver, as these provide the most accurate representation of the body temperature. Sadly, like all other things when trying to determine the time of death, most often we do not have the ideal conditions. First, the rate at which the body cools can vary significantly depending on the environmental conditions or the state of the body. Colder temperatures will increase the rate of cooling. Warm days or being outside may slow the rate. Also, the fat in the bodies can act as an insulator, delaying the loss of heat. Additionally, we can't always assume a normal body temperature from the start, as various factors can influence our internal body temp. Strenuous activity will elevate the body temperature, meaning a body will take longer to cool. However, even without exercises, our bodies tend to vary in temperature throughout the day, being cooler in the morning and warmer at night. Also worth mentioning is that a woman will tend to have a slightly higher normal body temperature than men. Under ideal conditions, we can just subtract the current internal body temp from the starting temp and add about 2 to 3 hours to determine the time of death. The Gleister equation pictured here can give us a little bit more accurate information. This still assumes ideal conditions, and it starts with a body temperature of 36.9 degrees internally. Then we insert the current rectal temperature at the time of discovery. This will give you an approximate idea of how much time has passed since the death. Another tool for using body temperature to calculate time of death is Hensch's nomogram. This method can be a little more accurate as it factors in variances in ambient temperature as well as utilizing a corrective factor that accounts for the person's weight, amount of clothing, location of the body, and other environmental factors. Corrective factors above 1 account for insulation of the body against heat loss, and factors below 1 account for things that accelerate heat loss. To use a nomogram, a line is first drawn to connect the current rectal temperature to the ambient temperature. In this example, you can see it as the blue line. Another line, which will be the red line, is drawn from the circle on the left with the crosshairs to where the blue line intersects the pre-printed black line. Next, you're going to find the curved line that corresponds to the deceased individual's body weight. This is where you would apply corrective factors that would be multiplied to the body weight and give you a new bona fide body weight. Where the curved line of the body weight meets the red line, this will be the approximate time of death. You can also follow the red line to the outermost line here that'll give you a standard deviation for that approximate time. In the example shown, this is plus or minus 2.8 hours. With all these charts and math, it's easy to see how calculating an accurate time of death can be a bit tricky. However, for learning purposes, we'll stick to the basics and make some assumptions for body cooling that you can use for exams and to impress your friends. First, unless otherwise indicated, you can assume that the ambient temperature is 23 degrees and the starting body temperature is 37 degrees, both in Celsius. Second, assume there are no significant temperature changes for the first 2 hours after death. Third, under normal circumstances, you can assume a rate of cooling of 1 degree per hour. However, you should still be aware of how the rate of cooling can be affected by the factors described previously. Finally, body temperature will reach equilibrium with ambient temperature. This means given our standard conditions, a normal body will reach ambient temperature after about 16 hours. Once the body has fully cooled to ambient temperature, algor mortis can only really tell us that the person has been dead for longer than half a day. To help tie the 3 types of postmortem changes together and demonstrate how they relate to the time of death, I've created this visual aid for you. I do encourage you to try and draw your own chart without looking up to further help you understand the concepts. The table here is also useful for giving a rough estimate based off a simplified breakdown of algor mortis and rigor mortis. The previous slides describe changes that are useful when dealing with the recently deceased, ideally having died in the last 36 hours. Now we will turn our attention to the process of decomposition. There are 2 terms you should be familiar with in regards to decomposition. First is autolysis, which is essentially self-digestion. As cells in the body start to die, they will release enzymes that will break down the rest of the tissue in the body. The second term is putrefaction. This is the breakdown of tissue by bacteria and is the primary process behind decomposition. Technically, the process of decomposition occurs immediately after circulatory death. However, the first signs won't appear until about 24 hours later, and this will typically be seen as a greenish discoloration in the lower abdomen, as the GI tract tends to be the first victim of decomposition. In the period between 24 hours and 36 hours, the green discoloration will appear in the head area as well, followed by a swelling of the eyes and the tongue. Decompositional fluid, or purge fluid, will begin to emerge from the nose and mouth. This fluid appears to be reddish in color and is often confused for blood, leading to a suspicion of trauma. However, this is predominantly just fluid of broken down tissue components of the body. Between 36 hours and 48 hours, the body will start to marble. A greenish-black discoloration will appear along the path of blood vessels as the vessels in the blood inside start to break down. The color is due to a reaction of hemoglobin and hydrogen sulfide, and it creates a pattern similar to what you'd see in marble countertops. After 48 hours, the putrefaction of the tissues internally results in gas formation. This will cause the body to swell. Additionally, the skin begins to turn green, then black, as skin slippage starts to take effect and the body starts to blister. This continues for 1 to 2 weeks as the bacteria continues to digest the tissue. After that time, the teeth and nails start to fall out as well. At about 1 month, the entire body will start to liquefy. As you probably guessed, the stages of decomposition described here can be heavily influenced by environmental factors, and the process we just talked about will typically take place in a moderate climate. In hotter climates such as that you see in Texas, you can see significant acceleration of these stages. In particularly warm and dry climates, the skin can take on a dark and leathery appearance, and the body can undergo mummification in as little as 3 months. In climates that are warm but humid, the body's fat will become hydrogenized through bacteria digestion. This process, which usually occurs after about 6 months, creates a brown wax-like appearance to the body known as an adipocere, and which is essentially just a human soap. Once all organic components have been lost, the body will become a skeleton. This process is the most variable and highly dependent on climate and potential scavengers. A body can achieve skeletonization in as little as a few weeks if the temperature is warm enough and animals are present to pick the bones clean. Or this could take years in cold environments, potentially leading to the preservation of soft tissue in the most extreme frigid conditions. The rate of decomposition is also affected by where the body is laid. A useful shorthand is Casper's law, which states that the body exposed to water will decompose twice as fast as one in the open and on land. A body buried in the earth will decompose 8 times faster than one on the surface. Finally, another method for determining time of death is forensic entomology. Not only will animals pick bodies apart, decomposing bodies become quite the feeding ground for many insects. Because specific insects have specific preferences as to how they like their decayed delicacies served, as well as having very regimented life cycles, entomologists can be called in to correlate the presence of insect colonies to approximate the time of death. And that's the end. You should all now be experts on external examinations, postmortem changes, and how to calculate the time of death. Thank you for your time, and please let me know if there are any questions.